Thank you. And I want to thank OEHA for involving me in this project. And this has really been a fascinating project. So again, I'll be talking about synthetic food dye exposures in U.S. children and also pregnant women and women of childbearing age. And I want to acknowledge other contributors to this, especially Rosemary Castorina and Ruan Del Carate and Mayala Gillen. They've really helped on this project, as well as the information we got from the UC Davis lab. So really, this has been a joint effort. I want to start with a little disclaimer here. The information in this presentation is preliminary and not peer-reviewed. The food dye exposure estimates and any comparisons to regulatory benchmarks are really for discussion only. And we're at the beginning stages of this project, and there'll be opportunities for public review of our draft reports, and certainly the final report will be available to everyone. So the objectives of this component of the project was to better understand artificial color exposures in potentially vulnerable populations, including children, pregnant women, and women of childbearing age. And those, again, we focused on the 7 approved FD&C food colors. So our specific aims, to drill down a little bit more, was to quantify single day, so often we think of as acute, and 2-day average exposures from food in children, pregnant women, and women of child age. Then we want to take that information, estimate potential exposures. We also wanted to estimate potential exposures from vitamins and over-the-counter pharmaceuticals, and then compare the exposures to the acceptable daily intakes, or the ADIs, from both the US FDA and from the JECFA Council. So I'm going to review our methods here. I want to emphasize and thank Dr. Doell for her presentation. And really what we did is adopt and adapt her methods to to this project. So a lot of what she described actually carries over into what we've done so far. So to focus first on exposures from food, we calculated single-day and 2-day food dye exposures based on 3 information sources. We used the 2015-2016 National Health and Nutrition Examination Survey, or NHANES, dietary interview information. So as part of that survey, they administered 2 single 24-hour recall questionnaires to participants in that study on different days. They weren't 2 days apart. They were separated by a certain amount of time. But again, they were kind of a classic 24-hour recall questionnaire. So we also focused on eaters, so somebody who consumed any of the 7 foods that contain any of the 7 FD&C food dyes. So very similar to what Dr. Doell did. We also used demographic data in that survey, of course, specifying age and body weight, which we'll talk about a little bit farther. And then we linked that with the food color additive concentration data from the database that was produced as part of the FDA study. So to be a little bit more specific here, we identified participants that consumed foods with at least 1 of the 7 FD&C food colors. And we linked that with information reported in the FDA study. So we met, again, similar to what Dr. Doell described, we mapped the food consumed to dye concentrations and then computed dye intake on a milligram per person per day basis, which is the way that Dr. Doell presented her information. And then we used information in the NHANES database on body weight and age, of course, to compute exposures on a milligram per kilogram per day basis, which is, of course, the units we use for the ADI and other exposure contexts. We also developed 2 exposure scenarios. One we called our typical exposure scenario, which is pretty much identical to what Dr. Doell described as her average exposure scenario. So in this case, where an NHANES food code represented multiple foods with distinct dye profiles, the dye concentration values across all foods with that code were averaged. So, and then in case where there were laboratory replicates, we simply took the average of those 3 replicates. So essentially we were mapping the exposure to averages of the likely intake. We also computed a high exposure scenario that was analogous to the FDA high exposure scenario. In these cases where an NHANES food code represented multiple foods, we selected the dye concentration, we selected the highest dye concentration across all the foods that were used for that code. In cases where there were laboratory replicates, we selected the highest value of those replicates. So this kind of creates an upper bound of the possible distributions. For study population, we generated information for pregnant women greater than 18 years of age. Again, this is demographic information that was available in the NHANES survey. We also looked at women of childbearing age between approximately 18 and 49 years. And then we broke down the children's population to look at a little more, get better resolution on exposures in different age categories. So we looked at children 0 to 2, 2 to 5, 5 to 9, 9 to 6, and 16 to 18. And this roughly compares to some of the age categories that OEHA looks at for risk assessment, but we even actually made that a little finer in terms of our resolution. So the reasons for looking at these age groups, one was to reflect important stages of fetal or child development. We included pregnant women and women of childbearing age to account for prenatal and perinatal exposures. And again, just getting at this concept of understanding exposures at different points in the life stage can, when there may be differing vulnerability in terms of development or susceptibility to an exposure, having this granularity helps us understand the risk better, potential risk better. So I want to kind of point out some differences here with the information that was just presented by Dr. Doell. One that I just touched on, we looked at more demographic categories, i.e. pregnant women, and then the finer resolution of children. We used the 2015-2016 NHANES food consumption data versus information from 2007 and 2010. We reported findings at the median and 95th percentile versus the mean and 90th percentile. So we used kind of some typical percentile distributions. And then we also looked at single day and 2-day averages versus the 2-day and 14-day averages that were examined in Dr. Doell study. So we're kind of looking at a lot of shorter time frame. So that also will account for some differences between what we found and Dr. Doell reported. So for the estimated exposures from vitamins and over-the-counter pharmaceuticals, we use the concentration data provided by UC Davis that we just heard about. We looked at the recommended dosages for the over-the-counter medications and vitamins. And then for body weights, we used the EPA Exposure Factors Handbook, the Child-Specific Exposure Factors Handbook, to get some estimates of likely milligram per kilogram per day exposures. So just to summarize very quickly some of the food dye results, I'll give you a few words and then we'll look at some numbers and then some pictures. Overall, the exposures trended higher for children compared with pregnant women and women of childbearing age, and that's not uncommon in some of the other studies we've seen that children tend to have higher intake of some of the foods that are likely to contain the synthetic food colors. In general, the highest exposures we found were for red number 40, which is, I think, very consistent with what we heard before, and then followed by red number 3 and yellow number 5 and yellow number 6. In this presentation today, we're kind of drilled down a little more closely on red 40 and red number 3, partly because some of the exposures encroach maybe on some of the ADIs. But in general, the patterns that we present for these two colors are going to be very similar to what we've seen for some of the other colors. And so again, this red number 40 was really the highest exposures to red 40 were highest among all the dyes, and they were particularly high in children 0 to 9 years. So a little different from the teenage boys that Dr. Doell looked at. And then for red number 3, we found some interesting findings, which I'll go into, that first in one category for the children, we found relatively high levels for a single day exposure. And we also tended to find that was for the very young children, 0 to 2 years. And also the highest 2-day mean exposure was in children 9 to 16 years. So this is kind of a verbal trend here. But first, to really go into more detail, let's look at a few numbers. But before we look at some numbers here, I just want to kind of reiterate here. We have, in these tables, we have day 1, day 2, and 2-day. So day 1 and day 2 are based on the single-day food recall questionnaire, and the 2-day is the mean over those 2 days. So again, when I talk about a 2-day mean or 2-day exposures, we're talking about an average of the 2 days, where a single day is just the information for 1 day. So clearly, there's a lot of numbers here. I don't expect anyone to be able to see these or read them, but just to highlight a few quick things. Again, we see this trend of higher exposures in children, also not very visible here, so we made a few pictures that I hope will be a little bit more clear. So again, this is for Red 40, and this is just comparing our typical exposures to our high exposures for the 2-day estimates. And just kind of the take home from this is just to give you a sense of the difference and the impact of the assumptions related to our typical and high exposures on our estimates. If you compare the typical to the high, you can see there, maybe a couple of factors lower. And you can also see that there's, pretty big difference between the median exposures, which are in red for each scenario, versus the 95th percentile for each distribution. So again, it certainly makes sense. We just heard a discussion about that relative to the 2-day versus 14-day exposure examined by Dr. Doell. When you start averaging exposures over more days, you kind of even out the variability. So here we're looking at the differences between a single and 2-day exposure. And again, this is for our typical scenarios. So what we're showing here is that if we look at the distribution for our 1-day versus our 2-day, it's higher, during the single day, and particularly the upper range and distribution is higher. So again, we see the impact of looking at acute, i.e. 1 day, versus averaging over a couple of days. And then if we look here, this is basically the same graph here. This is typical. I want to kind of point out here, if you look at these peak numbers here, they're around, around 2 for the single day and around 1 milligram per kilogram for the 2-day. Now we're looking at the same comparison for our high exposure, roughly similar, where we see some higher exposures for a single day. And notice also here on the single day, if you look at the upper exposures in the 95th percentile, here they're around 3.5 for the single day versus around 2.5 for the high. So again, just to make the point that when we look at shorter term exposures, there's more variability and we see slightly more extremes. So again, here's another table full of numbers. It's hard to see. We do see some similarities where we have higher exposures in the younger children. I'll show some pictures to demonstrate that. It'll be a little more clear than looking at this. But first, I also want to just call out, there were a couple of categories for single-day exposures, in this case, day 2 for Red 3, where we had some very high numbers at the 95th percentile, around 5 at our 95th percentile, even up to 8. And we found a similar trend also for kids. That was for kids 0 to 2. We found a similar trend here for kids in the 5 to 9 age bracket. It's hard to see here, but we'll look at it in more detail. Again, I'm showing some similar comparisons that we demonstrated for Red number 3. And again, you can see here with our, if we look at our typical exposures over 2 days compared to our quote unquote, I shouldn't say quote unquote, our high exposure scenario, again, you see there's about a factor of 2 or maybe 0.5 depending on the age category in terms of exposure. So again, the assumptions we make in the high exposure scenario certainly result in a higher range. Here we're looking at our typical exposure scenario, and we're comparing single and 2-day exposure estimates. And you can see here that at the median, the levels were quite low, but they're a bit dwarfed by these high 95th percentiles for the very young kids at 0 to 2, and also the third age group. I can't quite see the numbers here. It's a little hard on the screen, but the third age group. And again, these reflect those higher numbers that I showed you in the tables. And you can see here the numbers for the typical scenario around 4 or 5 in this very young group, and then around 1 or so for 1 day. And you can see it when we look at the 2-day average, we really lose that variability. It evens out. I want to make the point here too, we were concerned about these numbers, and we've done some QC and double checked our calculations. And I want to emphasize too that this is a 95th percentile, so it's not an outlier like we're just using the max value. There were a few measurements that were up in that high range in this age category. So again here, now we're comparing the high scenario between the single and 2-day, and now you'll see the numbers in these, especially in these 95th percentiles, are up around 8 in this very young category, and down here we're around 2 for Red 3. And then again, you see that, you know, again, for the 2-day scenario, we really average out that variability. So to compare them to the FDA and the JECFA acceptable daily intakes, we simply looked at the ratio of our exposure estimates and those ADIs. In general, the ratio, and of course, back up a little bit, when we interpret a ratio like this, if it was greater than 1, that means that we had an exposure exceeding the ADI. If it's less than 1, that means it's not exceeding the ADI. In general, we didn't really find many exposures that exceeded the ADIs except for Red number 3, and then I'll also talk a little bit about Red 40 later. For Red number 3, we had a number of exceedances of the JECFA ADI, which if you look down here, we noted earlier in Dr. Taylor's talk, there's a big difference here between the JECFA ADI is 0.1 versus US FDA, which is 2.5 currently for Red number 3. And again, we saw a number of exceedance of that. We'll go over that in detail. Almost all the ratios were less than 1 for the FDA, except for 1 single day category. So again, here's a pile of numbers that's a little bit hard to read, and I'll show you some pictures that make it easier. These yellows here is where we see some exceedances. You can see, so let me show it to you in visual form, which I think is a little easier. Just to highlight a couple things here, you'll see here that most of the exceedances are in the day 1 and day 2, or the single day averages, but we do see some exceedances down for 2-day averages in some age categories. So again, and this isn't our typical exposure scenario. So now to look at this visually, which I think is a little bit easier, this shows the ratios of our exposure estimates to the JECFA Red number 3 ADI, and you can see that for 3 age categories, those ratios exceeded the ADI. Kind of want to highlight here too that none of the, again, we just did ratios for the 2-day mean exposures just because we have a little more, just a little more certainty by kind of averaging out those much higher numbers. So none of the 2-day average exposure estimates exceeded the FDA ADI. And you can see for these 3 age categories, can't really see them very well, 2 to 5, 5 to 9, and 9 to 16. That's for our typical exposure scenario. Now this is the high exposure scenario. Again, you heard about the assumptions that went into this. So of course, some of the ratios are going to be higher than the typical. And if you look at this, in this case now, the four of the categories exceed the JECFA Red 3 ADI. This group here just barely crosses over the number 1. And then again, in terms of looking at the FDA ADIs, there were no exceedances based on the 2-day high exposure scenario. Some of the top foods that contributed to red number 3 and red number 4 included frostings and icings, vanilla wafer cookies, sugar decorations. Red number 40 also kind of stood out for a number of beverages that we looked at. And then ice cream cones and ice cream flavors came up for both of them. To look at kind of a picture of this, these were the top foods in our analysis contributing to red number 40 exposures. One of the biggest categories was flavored water and enhancers. So I kind of understand these as syrups, for example, that you might add to water. My adult version would be going to a cafe and getting a vanilla syrup added to your coffee or almond syrup. And then followed by some of the food categories that Dr. Doell reported in terms of icings and cakes. I'm kind of, again, I'm having this problem. It's very hard to read this small screen here. Just an example of a syrup or flavored water enhancer containing some of the ingredients we looked at in terms of colors. Some of the main contributors to red number 3 included icings, ice cream cones, and then some of the other foods that were comparable to many of the foods identified in Dr. Doell's analysis. Just a nice picture. I mean, I must say the foods look really cute and appealing. And you can see clearly how the icings and some of the other foods are likely to be major contributors. I know in my household, sprinkles are popular in the kid department. And it's just a reminder of when things even out, if they gave us the survey on a Saturday when we had ice cream, there'd be high sprinkle consumption. But if we took the survey on Wednesday on a school day, they're not eating ice cream. So we were also surprised to see that some other icing components were also significant contributors. The icings, even bright white icings and other white foods actually still contain a number of colors, including blues and reds and yellows. And so the visual take on a food doesn't necessarily reflect what you might expect in terms of colors. And icings actually proved to be a significant source for some of the reds that we saw higher exposures to. So the next piece of this was to look at the food dyes measured in the vitamins and cough syrups and pain relievers. And we just heard about the analytical work that underlies this analysis. So here we're presenting some of the exposure information for red 40 and blue 1. And as noted before, those were the two dominant colors in the syrups that we looked at, both in terms of pain relievers and fever reducers. And we calculated the dose, the exposures based on taking a single dose right here, or we looked at the label and then multiplied that by the number of doses that were considered acceptable for a day. And then we broke that down by individual age categories because some of the recommended dosing changed with age categories. Actually, I'll get to that in a moment. But again, based on these age categories, we also used different body weights from the EPA Exposure Factors Handbook. That's why you see differences in these estimated exposures on a milligram per kilogram basis. You'll notice here we have 5 doses per day for these lower brands, and that was just because for whatever their formulation is, they recommend up to 5 doses per day. The ADIs for red number 40 is around 7, and there may be some exposures in some age categories from some products that encroach on or maybe exceed that ADI, although these are less likely to be chronic exposures. Here's some information now here for the cold, cough, and allergy syrup, so a little bit different from the fever reducers here I'm sorry to make that clear. This focus on pain relievers and fever reducers like Tylenol and ibuprofen. And here we're talking about medicines with Delsym or other cough or Benadryl, cold cough, and allergy-related syrups. And similar findings in terms of looking at exposures on 1 dose 2 day versus up to 6, depending on the label. And then we do find for some categories that the exposures, in this case to Red 40, could be higher than the FDA ADI, well, and JECFA. Actually, the ADIs are same for both organizations here. None of the blue levels came close to the ADI. So you also note here that our age groups here start at 6 and 11 and 12 to 16, and that's because these products are not recommended for younger children. We also calculate exposures based on the gummy information, looking at both Red 40, blue, yellow 5, and yellow number 6, different age categories, again, based on the labels and the number of gummies they might take, and all of these measurements and potential exposures rated to the gummies were well below either the FDA or JECFA ADIs. So future directions, we're looking forward to more measurement data from UC Davis, particularly on some of these dyes in women's prenatal vitamins. We'll also be using the methods described above to estimate those exposures, and look forward to try to understand that in more detail. To summarize, we estimated exposures to the 7 colors based on single and 2 day intake for US children, the number of age categories. The food dye exposure estimates tended to be higher in children compared to pregnant women or women of childbearing age. The examples I presented for Red 3 and Red 40 carry over into trends for the other dyes as well. The 95th percentile Red number 3 exposure estimates exceeded the JECFA ADIs for women and children in many cases, depending on the scenarios, but fairly commonly. The 95th percentile of Red number 3 single day exposure estimate for one category for 1 day with children 0 to 2 exceeded the FDA ADI. Again, that was for a single age category and a single day exposure. Children's exposures to food dyes from some vitamins appear to be low relative to the ADIs, and that's in terms of looking at the gummy data we have so far. And then just kind of, an implication of our work with the cough syrups and the fever reducers, that they may be an additional source of food dye exposure in children, especially during an illness, and we should all think about how to consider that. So thank you, and look forward to any questions and discussion with the panel.